The 55-year-old man walks into your OPD. He can't swallow water. By the time you finish reading this case, his cancer has already spread. Why? Because the esophagus has no serosa.
Welcome to the deep dive. This is Surgical Thinking Academy. Surgery must be understood, not memorized.
I mean, if you're listening to this right now, maybe you're on your commute or grabbing a coffee between rounds, or honestly, maybe you're just staring down the barrel of the USMLE or NEED PG and you're just exhausted.
Completely burnt out. We know exactly how you feel. You're probably drowning in tables, right?
Oh, totally. Just TNM staging grids blurring together, lists of risk factors that all look identical, and the instinct is always to just, brute force it, just flashcard it into your brain until test day.
Right, but I'm telling you, you cannot do that here. If you rely on rote memorization for esophageal cancer, the boards will catch you. And worse, the wards will catch you.
Yeah, because memorization just strips away the actual mechanics of the disease.
Exactly. And if you don't understand the mechanics, you are dangerous to your patient. So listen to me carefully. This is not going to be a dry list of facts to passively consume.
Definitely not.
The esophagus is the one organ in the entire GI tract that actively betrays the human body. It is uniquely biologically designed to hide a tumor until it's lethal. And it all comes down to a single missing anatomical layer.
Right, the missing serosa.
Yeah.
And literally every clinical decision, every bizarre staging rule, and every brutal surgery we do traces back to that one fact. It's like unlocking a hidden code.
It is a code, and we're going to decode it today. If you understand this, you don't need to memorize a single textbook page. You can just derive the answers from first principles.
So let's map out the terrain first.
Yeah.
To understand the betrayal, we have to look at the baseline architecture. So the esophagus is basically just a muscular transit tube.
Roughly 25 centimeters long, yeah.
Right. But clinically, we don't measure it from where it starts in the neck, do we?
No, we don't. When a gastroenterologist goes in with a scope, they always measure from the incisors, the front teeth.
Okay, so when you see a pathology report, the cervical esophagus is marked at like 15 to 20 centimeters from the incisors.
Correct. And the thoracic portion is 20 to 40 centimeters. And then you have that tiny little abdominal portion at 40 to 45 centimeters.
But it's not a perfectly smooth, uniform tube. It has these specific anatomical traffic jams.
The three major constrictions, yes. You have the cricopharyngeus at 15 centimeters right at the top, then the point where the aortic arch and the left main bronchus cross over it, compressing it at around 25 centimeters.
Right, and then the final one at the bottom.
The diaphragmatic hiatus at 40 centimeters, that's where it punches through the muscle of the diaphragm to reach the stomach. These are absolute anatomical bottlenecks.
So if you swallow something rough, like a dry piece of meat, or, God forbid, a caustic chemical, those are the exact spots where the substance slows down and causes maximum trauma.
Exactly. So logically, those are the exact geographical coordinates where tumors are statistically most likely to originate.
That makes total sense.
Mm-hmm.
But the real story here isn't where the tube narrows. It's what the tube is completely missing. Let's get into the no serosa rule.
This is the cornerstone of the entire pathology. Think about the rest of the GI tract. The stomach, the colon, the small intestine, they all float around in the abdominal cavity sliding against each other.
Because they're wrapped in that tough, slippery outer layer, right? The serosa. It acts like a biological containment suit.
Yes, exactly like a containment suit. But the esophagus doesn't have it because it doesn't float in the abdomen. The vast majority of the esophagus lives packed tightly in the mediastinum.
So it's crammed in the chest cavity right up against the heart, the aorta, the spine.
Right. It doesn't need to glide. So embryologically, it just never developed a serosal wrapper. It only has this flimsy, loose connective tissue called the adventitia.
I always picture it like a chain link fence instead of a solid concrete wall. There's just no tough barrier to keep the cancer contained.
And that single omission has three devastating consequences that dictate everything we do. First, skip lesions.
Right. Because normally I think of a solid tumor growing outward like a sphere, pushing against boundaries. But here, there's no boundary pushing back.
So the tumor takes the path of least resistance. It dives deep into the submucosal layer. Now, the submucosal lymphatic plexus in the esophagus is incredibly rich.
The sources describe it almost like a subway system, right?
A high-speed, unpoliced subway system running right under the mucosa. The cancer cells drop down, hop on the train, travel maybe 5 or 8 centimeters up or down the tube, and then pop back up.
And they just form a brand new tumor island.
Exactly. And between the primary tumor and that new island, the tissue is Perfectly normal, healthy-looking pink mucosa.
Wow. So an endoscopist could go in, see a 2 centimeter tumor, push past it, see 5 centimeters of beautiful pink tissue, and think they caught it early.
But underneath that healthy pavement, the subway is packed with microscopic cancer cells. This translates into massive surgical morbidity.
Because you can't just take a little piece out.
Right. With colon cancer, a 5 centimeter margin is usually fine because the serosa contains it. In the esophagus, we routinely take 5 to 10 centimeter margins, sometimes more. We basically have to remove the whole organ.
Just to clear the microscopic subway spread? That is terrifying.
Hmm.
Which leads to the second consequence, right? Early nodal positivity.
It escapes the organ incredibly early, even for a superficial T1B lesion, meaning it hasn't even hit the main muscle layer yet. There is already a roughly 20% chance it has metastasized to the lymph nodes.
Wait, really? A 20% chance just from barely scratching the submucosa?
Yes. And if it hits the muscle, the T2 stage, that nodal metastasis rate jumps to 30 or 40%. It's out of the building before the fire alarm even goes off.
That stealth infiltration is just brutal. And then the third consequence is field cancerization.
Because the entire mucosa is constantly bathed in whatever carcinogen the patient swallows. Tobacco smoke, alcohol, hot tea, or gastric acid.
So the whole 25 centimeters is just genetically primed and mutating simultaneously.
Exactly. You might cure one tumor, and another primary pops up 18 months later from a different patch of condemned tissue. Or they have an esophageal cancer and a tonsil cancer at the same time. The whole neighborhood is burning.
When you put it like that, it's basically a rigged game. The anatomy itself is aiding the cancer.
It completely aids the cancer, and this has to govern how you view these patients. Listen closely. The esophagus has no serosa, no second chance it spreads before it screams.
So true. Okay, let's hold that intense reality and pivot to the cellular makeup. Because we treat esophageal cancer as one organ on the surgical board, but it's really two completely different diseases fighting for the same real estate.
Two entirely different beasts, born from different cell lines, driven by different behaviors, ravaging different halves of the globe.
Let's tackle the disease of the East first. Squamous cell carcinoma, or SCC. This dominates in Asia, Africa, the Middle East, and geographically in the body, it loves the middle third.
Which makes sense because the vast majority of the tube is lined with squamous epithelium. Just picture the skin on the back of your hand, but wet. It's built for friction.
Right. It's designed to handle a purely chewed carrot scraping down, but it's not invincible.
No, if you chronically traumatize that skin day after day, the DNA repair mechanisms eventually get exhausted. The cells mutate to survive, and that mutation turns malignant.
And demographically, SCC affects men and women almost equally, maybe a slight male predominance. But then we look at the rising tide in the West. Adenocarcinoma.
The modern epidemic, exploding in the US and Western Europe, and it completely ignores the middle third. It specifically targets the lower third, right at the gastroesophageal junction, the GEJ.
And the demographics flip completely. Adenocarcinoma has a massive male predominance, like 7-to-1, and it mostly hits Caucasian populations. Why are they so geographically and demographically distinct?
You have to look at the microscopic physiology of that Z-line at the GEJ. It's a stark, jagged border where the flat squamous epithelium abruptly transitions into the beefy red columnar epithelium of the stomach.
And border zones in the body are always areas of immense biological tension, right? Like the cervix or anal canal.
Exactly. Squamous cells handle friction, columnar cells handle acid. Adenocarcinoma is a glandular cancer. It only originates from those columnar cells or cells trying to act like them.
So when we talk about risk factors, we aren't just memorizing lists. We're looking at the specific kind of chronic torture we put these cell types through. Let's hit the mnemonics. For SCC, it's smoke, spirits, scalding sips, strictures.
A brilliant summary of chronic mucosal trauma. And with smoke and spirits, tobacco and alcohol, students always get this wrong. They think it's additive, like 1 + 1 is 2.
Right, but it's not. It's completely synergistic.
Exponentially synergistic. The alcohol acts as a highly effective chemical solvent. It physically strips away the protective lipid layers of the squamous mucosa, leaving the cells completely naked.
And then the incredibly concentrated carcinogens from the tobacco smoke just drive directly into those unprotected cells. The alcohol is the battering ram, and the smoke is the invading army.
Perfectly said. And what about scalding sips? The literature specifically calls out drinking hot chai in India or mate in South America.
Yeah, this is basically just recurrent thermal injury, right? Drinking liquids above 65 degrees Celsius.
You are literally causing microscopic first-degree burns to your esophagus multiple times a day. The cells die, they rapidly divide to heal, and then you burn them again tomorrow. Decades of that forced cell division causes DNA copying errors.
It's amazing how cultural habits map straight onto oncology. And then the final S is strictures, specifically lye or corrosive strictures. I always picture a toddler accidentally swallowing drain cleaner.
They survive the horrific acute burn, but the esophagus scars down. And the cancer doesn't happen when they're 4. It's a delayed detonation, a time bomb with a decades-long fuse.
Because the dense scar tissue ruins the peristalsis. Food gets trapped above the stricture, rots, and causes chronic inflammation for 20 or 30 years.
Exactly. And a highly aggressive SCC erupts right at that inflammatory war zone when they're 45.
Let's hit 2 high-yield exam associations for SCC really quickly. First, Plummer-Vinson syndrome, a middle-aged female with severe iron deficiency anemia, an esophageal web, and dysphagia. Why does lacking iron lead to cancer?
It's a tragic link between hematology and oncology. The squamous mucosa of the upper esophagus has a massive cellular turnover rate. It needs iron-dependent enzymes to maintain that.
So without iron, the enzyme systems fail and the tissue thins out and atrophies.
Right. It forms those fragile sail-like webs across the lumen. Every time the patient swallows, food hits the web, causing microtrauma. And chronic trauma to squamous cells breeds SCC.
Boom. And the other big one is achalasia, a massive 16 times increased risk for SCC appearing 15 to 20 years later.
Achalasia is a neuromuscular failure. The lower sphincter won't relax, and the tube loses its peristalsis. It becomes a dilated, stagnant bag. Food sits in the chest, fermenting and rotting against the squamous wall for decades.
So again, unremitting chronic chemical irritation. Oh, and tylosis, the rare genetic disorder with the super thick skin on the palms and soles. Almost 100% lifetime risk of SCC. If you see those hands, you scope them immediately.
Absolutely. So that's the yeast, a disease of friction, burns, and stasis. Let's fly west to adenocarcinoma. The mnemonic here describes the modern Western lifestyle: acid, adipose, ailing valve.
This isn't trauma. It's mechanical and chemical failure. Acid is long-standing, GERT. Adipose is central obesity, and the ailing valve is the mechanical failure of the GE junction, usually a hiatus hernia.
Let's connect the dots here. How does carrying extra belly fat directly drive cancer in your chest?
Yeah, it's all about fluid dynamics and pressure, right? Visceral fat drastically increases intra-abdominal pressure.
Yes, the stomach is being squeezed upward. The lower esophageal sphincter is a weak valve. When the pressure from below constantly exceeds the valve's strength, it blows open.
And if they have a hiatus hernia, that valve is physically pulled up into the chest, which is a negative pressure vacuum.
Exactly. An incompetent valve in a vacuum with high pressure pushing from below. You get a constant, unremitting geyser of corrosive gastric acid washing up into the lower esophagus.
Which brings us to the absolute, wait, what? Fact from the sources. We always think bacteria is bad. H. pylori is a class 1 carcinogen for stomach cancer. But the data says H. pylori is actually protective against esophageal adenocarcinoma.
This is why physiology beats memorization. Yes, H. pylori causes stomach cancer by causing severe atrophic gastritis. It destroys the parietal cells, and what do parietal cells do?
They secrete hydrochloric acid.
Right, so a stomach infected with H. pylori makes significantly less acid. The gastric juice is almost neutral.
Oh, wow. So if the stomach makes less acid, the reflux washing up into the esophagus is way less corrosive.
Precisely. The bacteria neuters the acid bath. A patient with H. pylori has a biological shield against the exact chemical trauma that drives esophageal adenocarcinoma.
That is just wild. The internal ecosystem is so complex. But that chemical trauma leads us to the critical battleground, because acid doesn't instantly turn squamous cells into cancer. There's a middle step.
The only premalignant lesion you absolutely must master, the Barrett's pathway. Let's walk through how reflux transforms a normal esophagus into a lethal tumor.
Okay, step 1, normal pale squamous epithelium and a functioning sphincter. Step 2, the sphincter breaks. Acid and bile splash up daily, burning the mucosa. The patient is popping antacids.
And this is where the body tries an evolutionary defense maneuver. Step 3 is Barrett's intestinal metaplasia. The flat squamous cells are burning alive in acids, so the tissue changes its genetic identity.
It looks at the intestines, which handle acid all day, and tries to mimic them. It morphs into plush, red, columnar mucosa with specialized goblet cells.
The goblet cells secrete mucin. The tissue is desperately trying to build a protective slime layer to prevent perforation. It's a brilliant survival strategy, but it carries a fatal flaw.
It's fundamentally unstable.
Highly unstable. You're forcing a cell to adopt a phenotype it isn't genetically programmed for in that location. This leads to step 4, dysplasia. The copying mechanisms start making errors. The nuclei get dark and disorganized.
From low-grade dysplasia to high-grade dysplasia. And high-grade is basically carcinoma in situ, right? It has all the malignant hardware.
It's standing on the edge of the cliff. And step 5 is invasive adenocarcinoma. The cells break through the basement membrane into the submucosal subway, and the nightmare begins.
But before the nightmare, we have a window to intervene. What is the exact clinical definition of Barrett's? If I'm a resident reading a scope report, what 2 things do I need to see?
2 distinct pillars. First, macroscopic visual evidence. The endoscopist must see salmon pink columnar mucosa extending at least 1 centimeter above the GE junction.
Okay, and the second pillar?
The absolute medico-legal requirement. Microscopic proof from a pathologist showing true intestinal metaplasia with goblet cells. If you have the columnar lining but no goblet cells, you do not have Barrett's.
And missing this is catastrophic because confirmed Barrett's amplifies lifetime risk of adenocarcinoma by 30 to 125 times. That is a staggering amplification.
Which is why strict endoscopic surveillance is a mandate. You don't just give them a PPI and say, call me if it hurts. You scope them rigidly.
So what are the intervals?
For non-dysplastic Barrett's, every 3 to 5 years.
Right.
If they have low-grade dysplasia, that shrinks to every 6 to 12 months. And high-grade dysplasia.
The guidelines say 3 months or immediate treatment.
Immediate endoscopic treatment is the modern standard. You don't wait and watch high-grade dysplasia, you go in aggressively. Endoscopic mucosal resection, or EMR, to physically cut out raised nodules.
And then you follow that with radiofrequency ablation, RFA.
Yes. You use a specialized balloon to literally burn and vaporize the remaining flat, unstable mucosa. Eradicate the whole field before a single cell invades.
A totally preemptive strike.
Listen and remember this on your GI rotation. Barrett's is the price of acid. Surveillance is the change.
Okay, I want to pull back from the microscopic level now. Let's look at the horrifying reality for the actual patient. Because they don't feel metaplasia. They don't feel dysplasia mutating.
No, there are no pain receptors sounding the alarm. What brings them into the clinic, usually way too late, is the dysphagia, difficulty swallowing.
The 3 Ps of malignant dysphagia. It is progressive, painless, and mechanical. Let's climb the dysphagia ladder. Walk us through a patient's timeline here.
Imagine a 62-year-old man. 6 months ago, he's at a steakhouse. He swallows a large piece of steak, and it catches right behind his breastbone. It doesn't hurt, but it won't go down. He has to drink a gouged glass of water to force it through.
And his immediate psychological response isn't, I have cancer. He just thinks, oh, I didn't chew it well enough. That's step 1, solids only.
The tumor is large enough to block maybe 40% of the lumen, but softer things still slip by. So because it's painless, he just subconsciously changes his behavior. He stops ordering steak.
You're right. He adapts to the cancer. And then we hit step 2. Now he's struggling with softer foods. Rice, idly, pasta.
The tumor is growing circumferentially now, like a tightening ring. He starts chewing obsessively. He takes tiny bites. He's always the last one at the dinner table. But still, no pain.
Then step 3, semi-solids. Even a bowl of dal or yogurt or mashed potatoes requires immense effort. The lumen is down to a few millimeters.
This is where the systemic effects become visually obvious. He comes into the clinic having lost 15% of his body weight. Not because the cancer is hypermetabolic yet, but simply because he physically cannot swallow enough calories to survive.
He is literally starving. And step 4, liquids. He tries to drink water and immediately regurgitates. He chokes. He's rapidly dehydrating.
And the final agonizing step. Step 5, aphasia. Complete 100% obstruction. He cannot even swallow his own saliva. Picture him in your waiting room holding a little plastic cup, constantly spitting his saliva into it because it has nowhere else to go.
It's just a horrifying, undignified progression, which gives us 2 back-to-back clinical aphorisms for history-taking.
Never assume it's just a spasm or bad reflux. Dysphagia in any adult is cancer until proven otherwise. And always ask what order they struggled with food. Solids first, then liquids. That ladder leads only to a malignant lumen.
Compare that to achalasia, where they struggle with liquids first or both at once because the nerve is dead. The strict mechanical progression is a physical tumor closing the door.
Exactly. So by the time they are spitting saliva into a cup, the tumor is massive inside the lumen, and because of the no-cirrhosis rule, it has almost certainly breached the outside of the tube.
So what are the red flags of local T4 invasion when it breaks into the mediastinum?
Well, if it grows anteriorly, it can invade the recurrent laryngeal nerve. That nerve loops down under the aortic arch and comes back up to the vocal cords. If the tumor paralyzes it, the patient's voice becomes distinctly, chronically hoarse.
So hoarseness isn't a bad cold, it's nerve invasion. What about a patient who coughs violently, specifically when they try to swallow?
That is pathognomonic for a catastrophic tracheoesophageal, or TE, fistula. The tumor has eaten straight through the esophageal wall and into the trachea. The two tubes are now physically connected.
So every time they swallow water or saliva, it pours directly into their lungs. They basically drown in their own intake.
Rampant aspiration pneumonia. It's a tragic, often terminal scenario. The sources also mention Horner syndrome.
The triad of cautosis, meiosis, and anhidrosis. Drooping eyelid, constricted pupil, lack of sweating. That's invasion into the cervical sympathetic chain,
Right.
usually from tumors high in the neck.
Yes. And then there is the absolute physical exam non-negotiable. When that patient is in front of you, before you order a CT, you must stand behind them and deeply palpate the space just behind their left collarbone.
Troisier's sign. Finding an enlarged, rock-hard Virchow's node in the left supraclavicular fossa.
Why the left side? Because the thoracic duct drains lymphatic fluid from the entire abdomen and lower chest straight into the left subclavian vein. If you feel a hard mass there, the cancer has marched all the way up the highway.
Palpate it on every dysphagia patient, because finding it changes your plan from curative to palliative instantly.
Exactly. And we also look for distant hematogenous spread. The liver catches about 35% of bloodborne metastases, the lungs catch 20%, and lower third adenocarcinomas can cause transcoolomic spread, seeding the peritoneal cavity and causing massive ascites.
So once it's in the blood or fluid, we shift to palliation, which is why the investigation's workflow is so critical. We have to stage this precisely. The mnemonic is ECQPB. Step 1 is diagnosis, the E.
Endoscopy. Upper GI endoscopy with biopsy is the absolute investigation of choice. Go in with a camera, see the tumor, take 6 to 8 deep biopsies to prove the histology.
And we completely ignore barium swallows, right?
Yeah.
Even though exams love to ask about the apple core or rat tail signs.
They are beautiful on a radiograph, but useless for modern oncology. An apple core lesion just means a massive advanced tumor. The patient spitting into a cup already told us that. A barium swallow can't give you tissue, it can't test HER2 receptors, and it can't tell you the depth of the tumor. Endoscopy is king.
Okay, we have the biopsy. It's cancer. Step 2, local staging. T stage for depth, N stage for local nodes. And here is a massive table-pounding point.
Stop scrolling and listen. If this comes in your NEAT PG, the answer is EUS. Always EUS for T-stage.
Endoscopic ultrasound. Why is sending an ultrasound probe down the throat better than a high-res CT scan?
A CT scan is great for macroanatomy. It can show if a massive tumor is invading the aorta, but it lacks the resolution to differentiate the microscopic layers of the esophageal wall. It cannot tell a T1B from a T2.
And that millimeter difference dictates if they go to surgery or get 3 months of toxic chemo first.
EUS puts a high-frequency probe directly on the tumor from inside. It beautifully delineates the mucosa, submucosa, and muscularis as distinct black and white bands. It is the undisputed gold standard for measuring exact depth and biopsying regional nodes.
Okay, EUS for T-stage. The C is just a CT scan for a baseline anatomical map. Then step 3, distant staging, the M stage. The P is PET-CT.
Functional imaging. We inject radioactive FDG. Cancer cells are hyperactive and ravenously consume glucose. The PET scanner lights up those areas like a Christmas tree, finding tiny metastases in the liver or bone that a CT might miss.
And the B is bronchoscopy, specifically for upper and middle third tumors, to make absolutely sure the airway isn't invaded before opening the chest.
Yes, you must know the airway status.
Okay, we have our imaging, we're ready to stage. And here we hit the AJCC 8th edition update. This is heavily emphasized.
It's a fundamental update that confuses everyone. Celiac lymph nodes in the abdomen and supraclavicular nodes in the neck are now classified as N, regional nodal disease. They are not classified as M, distant metastasis anymore.
Wait, really? If a tumor is all the way down in the lower abdomen at the GE junction, how is a node all the way up in the neck just regional spread? That used to be an automatic M1 stage. game over.
And this is exactly what drives me crazy. Students just memorize the AJCC tables without understanding the anatomy. They look at the physical distance on a 2D diagram and think, "Ooh, the neck is far from the stomach. It must be distant metastasis." No, look at the plumbing.
Are we talking about submucosal plexus again?
Always the submucosal plexus. The lymphatic drainage here doesn't respect the diaphragm or the thoracic inlet. The plexus runs continuously along the entire length of the tube with bidirectional flow.
Right, so fluid from the bottom can flow straight up the highway to the neck.
Exactly. The intrinsic anatomy provides a direct, localized highway. So that node is regional no matter how far away it looks on a scan. If you understand the bidirectional plumbing, the AJCC8 update makes perfect, logical sense.
Wow. The plumbing defines the region, not the zip code. And because they're considered regional, end stage, these patients are technically still operable. Which brings us to the surgeries.
Arguably the most physiologically stressful operations performed on the human body. We operate across the belly, the chest, and the neck, often in a single sitting. We have the big three options.
Surgery number 1, the Ivor-Lewis esophagectomy. For lower and middle third tumors, a 2-stage operation, laterotomy plus a right thoracotomy.
We start in the abdomen, mobilize the stomach, and staple it into a long tube. Then we close the belly, flip the patient onto their left side, open the right chest cavity, cut out the diseased esophagus, and pull the stomach tube up into the chest.
And you sew them together right there in the chest, an intrathoracic anastomosis.
Correct.
Surgery number 2, the McCune esophagectomy. For upper and middle third tumors, a massive 3-stage marathon.
Stage 1, belly to prepare the stomach. Stage 2, right chest to dissect the esophagus and nodes all the way to the top. Stage 3, we turn the patient on their back, make an incision in the left neck, pull the entire esophagus out through the neck, cut it away, pull the stomach all the way up through the chest, and sew it together in the neck. A cervical anastomosis.
Pulling the stomach into a patient's neck is just wild to conceptualize. And surgery number 3, the transchiedal or Oringer esophagectomy for lower tumors or frail patients.
Right. If a patient has severe COPD, we want to avoid cracking the chest. We open the belly, widen the diaphragmatic hiatus, and the surgeon reaches their hand blindly up into the chest cavity from below to bluntly dissect the esophagus. We make a neck incision, pull it up, and do a cervical anastomosis. It saves the lungs, but limits our ability to clear out chest lymph nodes.
And you always use the stomach as the replacement conduit.
First choice, yes, because of its robust blood supply. If it's unavailable, like from a past gastric bypass, we use a section of the colon, carefully preserving its blood vessels. For extreme salvage cases in the neck, we might take a free graft of the jejunum and hook up its tiny vessels under a microscope.
The overarching fear with all of these is that the anastomosis will fail and leak, and the location of that leak dictates everything.
This rule is etched in blood in every thoracic ICU. Cervical leak you can drain. Thoracic leak drains the patient.
Unpack that reality for us.
If you do a McCune and the neck connection leaks saliva and bacteria 5 days later, you just open the neck wound at the bedside, wash it out, and put in a drain. They survive. But if you do an Ivor-Lewis and that connection leaks deep inside the negative pressure void of the chest,
It just pours gastric juice and bacteria straight into the mediastinum.
fulminant mediastinitis and septic shock. They often die within days. It literally drains their life force.
That is a terrifying tightrope.
Yeah.
And historically, surgery alone wasn't curing people. Which brings us to the Cross regimen.
The Cross trial completely rewrote the standard of care. Before Cross, we'd do perfect surgeries, but the cancer would recur a year later from invisible micrometastases that had already escaped.
So Cross is neoadjuvant chemoradiotherapy, heavy weapons before the knife.
Weekly cycles of carboplatin and paclitaxel combined concurrently with 41.4 gray of targeted radiation over 5 weeks. We hit the tumor locally and flood the system to kill circulating cells. We let them recover, then we do the esophagectomy.
And it literally doubled median overall survival for locally advanced disease. How does it help the surgeon in the OR?
It downstages the tumor. A bulky T3 tumor might melt away to a tiny fibrous nub. Sometimes we find a complete pathological response with 0 viable cancer cells left in the resected tissue. It drastically increases our chances of a clean R0 surgical margin.
Do SCC and adeno respond the same?
Biologically, no. SCC is more sensitive to chemoradiation, so we see higher rates of complete response. But adeno often has slightly better long-term surgical outcomes regardless.
But there's a huge catch. Putting a starving, frail patient through 5 weeks of toxic chemo and a massive surgery.
Their body has to be able to handle it. You cannot operate on a starving patient. These people have been suffering from dysphagia for months. They are profoundly malnourished. Treat the patient, not the tumor. Nutrition before knife.
So you actively intervene before treatment starts.
We often surgically place a feeding jejunostomy tube directly into their intestine the moment they're diagnosed. We pump them full of high-calorie nutrition throughout the cross regimen. We have to reverse the starvation before subjecting them to the knife.
So we have the complex biology, the US staging, cross chemo, and barbaric surgeries. But the prognosis reality check from the sources is devastating. 70% of patients are already locally advanced or metastatic at diagnosis. The 5-year overall survival rate is less than 20%, and if they are stage IVB, it's under 5%.
The statistics are undeniably grim. It is a highly lethal malignancy.
I have to ask you then, with a 20% survival rate, knowing how brutal a mekeone is, knowing they might suffer a fatal thoracic leak, why do we even operate? How do you justify putting someone through that?
That is the most important question you can ask. And you have to step away from the cold data and survival curves. You have to look at what this disease actually does to a human being.
The aphasia.
Yes. Think about what it means to be physically incapable of swallowing your own saliva, to constantly choke, to carry a spit cup everywhere, to be completely unable to sit at a dinner table with your family without panic and shame. It strips away all human dignity.
It's forced social isolation on top of starvation.
Even if the surgery only buys them 2 years instead of a cure, even if it's technically palliative, if I can take out that rotting mass, pull up the stomach, and give that person the ability to sit at their daughter's wedding and safely swallow a glass of water, that is a profound restoration of their humanity. We operate to save lives, yes, but when we can't save the life, we operate to save the dignity of the life that remains. That is why we pick up the knife.
Wow, that completely reframes the entire purpose of the intervention. It's not just about length of life, it's about the mechanics of living it. So to recap the core frame today, the lack of a serosa dictates the rapid submucosal spread, the skip lesions, the early nodes, the brutal dysphagia ladder, and the extreme surgeries. 2 histologies, SCC from trauma, adeno from acid, both exploiting the exact same anatomical weakness.
It all traces back to the anatomy, but before we go, I want to leave you with a provocative thought about the GI ecosystem. We noted that H. pylori is highly protective against esophageal adenocarcinoma because it destroys acid-producing cells in the stomach.
Right, but right now, we have massive global health campaigns aggressively using antibiotics to eradicate H. pylori in everyone to prevent stomach cancer.
We do. But consider the ecological consequence. If we systematically eradicate the exact organism that naturally dampens gastric acid across the population, are we inadvertently removing the biological shield that protects the esophagus?
Oh, wow. So by trying to cure the stomach, we might be unknowingly fueling the massive spike in Western esophageal adenocarcinoma?
Exactly. Sometimes our arrogance in sterilizing a local environment destroys the broader protective ecology. Think about the unintended consequences.
That is a chilling thought to leave on. Keep thinking critically. Keep questioning.
Yeah.
Because surgery must be understood.